All right. Thank you again, like I said, for being here. Good afternoon. My name is Renee Hawkins. I'm the Education Manager with the Michigan Center for Rural Health. The Michigan Center for Rural Health is a nonprofit state office of rural health. And a cornerstone of our office is providing free education for rural healthcare providers. I will be the facilitator for this program, and I would like to welcome everyone to today's Oral Health Grand Rounds. Just a few housekeeping items. This program provides continuing education for dentists, dental hygienists, dental therapists, and assistants for 1 contact hour, approved through the Board of Dentistry. And for successful completion, you have to participate in the learning session and complete a post-session evaluation, and you'll have that at the end at the survey. The survey will have a QR code up, and I will drop it in the chat as well. And there is no commercial support for our program, and no one that had the ability to today's content has any disclosures to disclose. And then upon completion of this activity, participants will report increased knowledge and awareness of dental treatment for patients with special healthcare needs. And then, like I said, at the end, we will have that evaluation. If you could do that within the next, immediately preferably, and if not within the next 48 hours, that would be greatly appreciated. And with that, I will introduce to you Dr. Brian Turvo. He is the interim director at the Integrated Special Healthcare Clinic in Ann Arbor at the University of Michigan. Thank you so much for being here. I greatly appreciate it, and I know our providers do as well. So with that, I will leave it to you.
Title slide up.
Yep, looks great.
Great, thank you. Thank you for having me. This is my first official presentation in the capacity of the director of this clinic. So I'm excited to give it, and I hope to provide some useful information, and I'll try to leave time for questions at the end. I tried to wait to the last minute to turn slides in, which should be available later if you're interested. I waited to the last minute because we literally just opened our clinic for patient and student activities this past Monday. So I wanted to try to provide as current information as I could. And that just came online this week. But basically for the next time here, I wanted to go over some things about appropriate levels of care for patients with special health care needs, provide some tips and tricks. The actual management and patient care for patients with special health care needs is a whole lecture in itself. So I kind of wanted to go a little bit into basically how this clinic came to pass, some of the changes in dental education that helped develop this clinic, and go over some of some broader strokes about treating patients with special health care needs, and also provide a little bit of information about the clinic here that we have to treat patients, but also educate the students to treat patients with special health care needs. As was discussed, I will be talking specifically about some products and some websites that offer, I think, some very helpful information for treating this patient population, but I don't have any financial relationship or otherwise with any of these companies. I just really like their stuff. Just quickly about me, I've been around a lot. I've Next month is my 25th anniversary from dental school. I did a GPR. I've taught at a bunch of different schools, Harvard, Ohio State, most recently Oregon Health and Science University in Portland. And in one form or another, I've been treating patients with special healthcare needs for the bulk of this time, including when I had my own practice for 5 years. I was part-time in the GPR at Ohio State, mainly going to the operating room to treat these patients. And I was brought here last July. July 4th was my first day. And I was recruited here to basically run this clinic. It was built, but I was recruited here to help get it going, operate it, and make it a useful, viable product. And so it's taken every bit of 10 months, but we're literally just getting the ball rolling this week on this clinic. As a point of reference, just to start sort of a jumping off point for patients with special health care needs, I figured this was a good enough working definition as any. Basically, just it's very broad. I think that to the lay public, you know, when you talk about special health care needs or patients with special needs or dental patients with special needs, I think people automatically have a tendency to go to patients with intellectual disability. And I think that this definition is much broader than that. And it's really any patient that requires some sort of modification so that we can treat them in a safe fashion, and productive, and in a productive way. So the challenges or the things that might require modification can be anything from physical to developmental, to behavioral, cognitive. And so what type of changes do we need to make to treat this patient population safely? These conditions that the patients come in with can be congenital, they can be developmental, acquired. So it's really a much broader definition than I think a lot of people think that it could be. It could be a long list of medical concerns in a neurotypical patient. It could be somebody that's neurodivergent, but also then has physical issues. So, but what type of modifications do we need to make to treat them safely and predictably? So this is sort of my definition. It's fairly broad. As it pertains to the Americans with Disabilities Act, you know, it really requires all professionals to at least try to treat people with disabilities in the same manner that they treat all of their clients, patients, et cetera. And so what do dental offices need to do to provide reasonable accommodations to their patients? This doesn't mean that every office needs a wheelchair tilt or a Hoyer lift or be able to accommodate a gurney. I think that the definition of reasonable is subject to interpretation, but at least you have to give the patients the ability to try. If you do require special equipment, then it requires the office to refer the patient to a place that can meet their needs. When I bought my practice in 2007, it was in a 100-year-old building. And having worked with patients with special health care needs for a long time, I sort of walked in and saw some things that didn't really fit. I ended up needing to talk to the building owners, and we needed to put a wheelchair ramp in and make the practice more accessible. It wasn't, you know, certainly able, it didn't end up being able to accommodate everybody that needed an accommodation, but I think it was better than when I bought it, to really help provide these reasonable accommodations to patient. And so I think the tenor of this is that we either need to provide the accommodations or find some place that can. Just, I personally feel like telling patients, well, I don't know what to do and I don't know how to help you, so good luck. I don't know that that's an acceptable approach. So if we don't have to know all the answers or have all the answers, but I think we should be able to at least try to find people that can. I think that's the tenor of that. But because practices aren't always equipped to handle all patients with special healthcare needs, many are referred. Where do they get referred? To the local dental school, to a local hospital residency program, or a lot of adult patients that are neurodivergent end up getting referred to a pediatric dentist, which the irony is not lost on me to have a 26-year-old patient with a neurologic deficit or a disability being seen by a pediatric dentist. And I think that, the idea of this clinic and, as we grow, is to try to take that burden off of pediatric dentists. There are a lot of pediatric dentists, again, from this survey, it's a little dated, but I think it makes the point that pediatric dentists would love to assist, their neurodivergent patient population and patients with physical disabilities to adult care, but a lot of times they don't know where to send them. Try to find a general dentist or specialist who's able and willing to treat this patient population, at least according to this 2010 paper, was a challenge for them. And having taught at a number of dental schools, that's certainly understandable, because a lot of schools just don't, or didn't, I guess, have this as part of their curriculum. So where do we send them? And I think that a lot of people, at least when I introduce myself and what I do, I've been referred to as a hospital dental specialist, and that's not a thing. I am a general dentist by training. I'm not a specialist. There's no specialty in it. Special Care Dentistry Association does have its own fellowship, but it's not a specialty that's recognized by the American Dental Association like the others on this list. So when we talk about access and trying to find where to send these patients and how to help them, again, we'll send them to the hospital dentist. That's not a thing. So we send them, let's find a dental school or a GPR, a hospital-based residency to send them to. According to the state of Michigan, there are over 2.3 million adults that have some form of disability, whatever that is, whether that's physical, neurologic, cognitive, and that's a lot. When you look at then the ratio of, the 68 dental schools in the United States, 2 in Michigan, 175 hospital-based residency programs, 33 of which are operated by the VA. And then there are 2 hospital-based dental programs in the state. One's here at the University of Michigan and one's at St. Joseph Mercy in Pontiac. And that's it. So, we have started to get a lot of referrals. We see a lot of patients in our emergency clinic here that literally come from all over the state. There was somebody in this week, yesterday, today, from Battle Creek. So people are really, access to care is a huge issue for patients with special healthcare needs. It's just not something that's readily available in every community. Here's a more recent study out of Pontiac, which again shows sort of the supply and demand issues when it comes to the supply of patients needing care and the demand of dentists that are comfortable providing this care. This was 2015, but the result of the study was showing 140,000 persons with some sort of developmental or acquired disability, but only 36 dentists that indicated that they would be comfortable treating patients with special needs. And so again, a supply and demand issue that's been a problem for a long time. So the American Dental Association and the American Dental Education Association kind of, heard the alarm finally. And in 2019, 2020 started to make these changes to the dental curriculum, saying that all of the schools in the country must now revamp things to include better training, if you will, for patients with intellectual and developmental disabilities. So it wasn't enough. The old standard used to be, well, they have a lecture or they have 2 weeks in the hospital. When a 3rd year, 4th year dental student goes to the hospital, they're not Uh, They're not doing much. When they would go in the hospital with me, I would have them put gloves on and stand there and hold a suction. So they felt like they were a part of it, but it's not really a direct management of patients with special health care needs. They're a part of the process, and they would have a lecture, um, maybe their second year, and it was probably in a pediatric dentistry course. But they weren't learning directly how to do it. It's hard enough to teach a dental student, how to do a 3 or 4 surface restoration for the first time on a healthy patient, on an ASA1 patient that doesn't have a neurological deficit. And so I think that that's where schools spent most of their time and focus in education. Let's just focus on doing, something quote unquote straightforward on a straightforward patient and do it perfectly and learn how to do that stuff. But, much less try to do one of those procedures on somebody in a wheelchair. But now they're changing the standards. This is the most recent standard from the Commission on Dental Accreditation, where they're saying that dental students now must graduate and be competent in assessing and managing the treatment of patients with special needs. And there's their definition of patients with social needs, which sort of fits mine, in that it's anybody with any of those situations where a modification to care is necessary. And so what we end up seeing in a lot of different schools is now these changes to the curriculum so that these students now have direct contact with these patients. And it's not just, oh, I see somebody in a wheelchair, I need to refer them. Or I see somebody that has crutches for cerebral palsy. Nope, can't see them. They have to go to the hospital. The Commission on Dental Accreditation is now forcing this to be learned in schools, and they're telling them you have to learn the basics on how to treat these patients. And so clinics like this one here, the Integrated Special Care Clinic, are popping up all over the place. And some of them have a lot more to offer than others. I've had many conversations with the director of the clinic at the University of Pittsburgh. I've visited the clinic at the University of Pennsylvania, New York University. They have these absolutely wonderful clinics, and their students are really learning a lot. And I had a chance to sit and talk with them and basically interview them. And they're super, super grateful for the opportunities they have to learn in these clinics. And so when we teach this process, what I'm trying to teach them is that the goal is we want to provide quality care to patients with or without special health care needs. The ultimate goal is to try to treat everybody approximately the same. And what might be different with people is where and when the events take place. Some patients we can see in the clinic, some patients we can see in the clinic with some modifications in place, some we have to take to the hospital. But, I personally feel like everybody can be treated. It's really just a matter of finding the most appropriate venue for care that will provide safe and predictable dental treatment. So where do we see them? When and how do we perform these procedures to try to really ensure that we can get the best possible result for the patient under their circumstances? When I say try to treat everybody the same, when they say, hey, do I look familiar? I say this because this is sort of the goal that we have for all of the patients that we treat in the special healthcare, the special care clinic. We want to review their medical history. We want to take radiographs, do an exam, develop a plan, treat them, get them on a recall or recare program. And I say, does this look familiar? And I show this to the students, and then like, well, this is exactly what it is downstairs. This is exactly what it is in the rest of the clinic. Sometimes the order of events has to change and whatever, but the goal is the same. We really want to try to treat everybody the same. And maybe we can't do that here. Maybe they do have to go to the hospital, but we try, we approach everybody with the same goal in mind. So for each person, we try to determine what's the appropriate level of care. Is that in our clinic? Is that in the clinic with some form of protective stabilization? Do they need some type of sedation with possible stabilization? Do they have a situation where they need to have IV conscious sedation, which is not a service that's offered here in the school or the hospital? We've had that as an option at other institutions I've worked. I have a moderate sedation permit, but I'm also the only faculty member here right now. So to try to teach the sedation and administer the drugs and do the dentistry and teach the stabilization would potentially not be safe. So for the moment, we're not offering that here. And general anesthesia in an operating room setting is offered at Michigan Medicine over in the hospital, but IV conscious sedation is not. But so which level of care is most appropriate for the patient given their medical social presentation? And that needs to be determined as you go. To the specific discussion of this clinic, this clinic was built many years ago, but hasn't had the proper staffing ability. But it was built to provide a level of care that's a little bit more advanced from the student clinic. We are providing the same procedures that are performed in the student clinic, but it's a little more complicated patient population. And also, because they might be a little more complicated for the clinic, that may not mean that they have to go to the hospital necessarily. So we're trying to keep patients out of the hospital when we can, because they're just busting at the seams with their demand. Like I said, there just aren't enough resources for the patients that need to be treated there. So the patients that are too complicated for the student clinic sort of get caught in limbo. And so this clinic was built to try to help meet that need. The third-year dental student who's just learning how to do a filling, they see a patient with cerebral palsy or in a wheelchair, Parkinson's disease, that might be a little bit outside of their scope, but maybe that person also does not need to be in the hospital. So this is what we're hoping will be an appropriate venue for them to receive care. So one of the things that I really tried to take a lot of time developing, and this, we're still sort of working out some of the tweaks, but we really wanted to try to have a robust referral system. We wanted to try to have a robust referral system, both externally from outside providers and internally, for a lot of reasons. But these are screenshots of our external referral form. And right now, so if that's the link right there, the referrals.dent.umich.edu. So if a provider, dentist, physician fills this out and returns it, it goes to, I guess, my attention and the attention of the referrals team at the hospital. We will review it, decide where the patient would be best routed, and send them that way. We ask for as much information as we could possibly get, to just check the medically complex box and leave everything else. If you click those little boxes, you get text boxes to articulate things. And, certainly the more information that we have, the better. We can determine, we don't want to waste anybody's time. I don't want to have a person here if they need to be at the hospital. I don't want a person in the student clinic if they can be here. So we're trying to gather as much information as we can, because we know patients are coming from all over the state, and we want to make it as efficient as possible. We don't want people driving here 2.5 hours to find out they're in the wrong place. So this is one thing that we're working on from an external provider standpoint. Once we get that, like I said, the review form is the referral form, is reviewed. And hopefully the referral will indicate exactly what accommodation we can provide so that we can figure out where the appropriate place for the patients to go. This is a sort of a non-exhaustive list of conditions that we will accept here in this clinic. as far as what we're trying to teach students and how to teach them not to be afraid, not to be afraid of somebody with a developmental disability or a progressive neurologic condition, or maybe they're in a wheelchair, need some sort of mobility aid. We can't treat patients on a gurney just logistically. The layout of the clinic and the corners are too tight and all of that. But you know, if somebody is in a wheelchair or something like that, we can accommodate them. And you know, I want the students to be able to approach these patients with more of an open mind and not be afraid. Let's give it a try. Again, you know, to reiterate, we don't, we're unable to provide any kind of IV sedation or oral sedation or general anesthesia at this time. That's my long-term, that's one of my long-term goals. My long-term goal list is pretty long, but you know, one of them is I would love to work closely with a dentist anesthesiologist. You know, I taught at Ohio State for 10 years and they have a dental anesthesia program. And I think I got a little spoiled, you know, just being able to lean over the wall and say, hey, I think we need to sedate this person, and they would drop the IV and let's go. And so I don't have that here, but I would love to be more of a full service operation and really be able to treat people with sedation or have general anesthesia here. And just really be able to expand the scope of services that we can offer. But at this time, we're unable to do that. Part of trying to figure out where the patient is best seen, whether that's the student clinic, this clinic, hospital, or somewhere else for that matter. This was an idea given to me from the University of Pittsburgh Special Care Clinic, and I loved it. What we do is we send the patient, once we say, yeah, that looks like something we might want to take a crack at. Oh, sorry, I got a chat message. I'll hit the chat messages when I'm finished. Thank you for sending that. We're trying to be very, very deliberate about the patients that we see. Again, last thing I want to do is waste people's time. So when we get a referral and we say, yeah, that looks like something we can handle, we're sending them a welcome packet, and it's what I'm calling a welcome packet and they call a welcome packet. And I took theirs and asked their director, can I use this with your permission? And she said, absolutely, I hope you will. That's why I made it, so that it can be used nationwide. And so I took it and we send this to all of our prospective patients. And it's big. I think it's 12 pages, but it's only in paper right now. I'm working on the electronic version. I'm not there yet, but I'm trying. Literally as we speak, I'm trying. But we give this to them, and it contains their medical, dental histories, social behavioral records, also documentation about who makes the medical decisions if it's somebody other than the patient. We want to be able to learn as much as we can about the patient before they get there. How can we help them? How can we be prepared for their visit? What do we need to have in place so that when they come in, you know, we already know this, you know, example, like we already know this patient on the autism spectrum really gets agitated at loud noises and wants everything as quiet and still and whatever as possible. And if you do that, they're great. Okay, so we know that. We know that then when the person checks in, maybe we bring them straight back to the room and we can close the room and we can dim the lights and we can give them a weighted blanket if that's would be helpful for them. You know, we know that before they get there so that we can try to stay ahead of anything that's going to agitate them. And we're trying to, you know, because we only have certain rooms that can accommodate wheelchairs. Somebody's coming in a wheelchair. Well, okay, well, let's prepare. Let's get this chair out of here. This person needs our wheelchair tilt. I mean, whatever the case is, we can be ready when they get here. So we're not trying to react to the situation when they show up. Some of these patients are very complex. And so the last thing I want to do is have to react to something, take time doing that, learn about that, make a mistake, agitate somebody. And so let's try to stay ahead of it and be prepared. So this is an example of, well, this is the medical history portion of the packet. And it's also a little bit of behavior history. So it's just a couple of pages, but we want to learn. Tell me about your, cerebral palsy, or tell me about the autism spectrum. Autism spectrum is vast. I mean, I don't think you'd mind me saying it right now. My son is on the autism spectrum, but he's also in college. He just finished his freshman year of college. He has a 3.9 GPA. He has a girlfriend. I mean, you'd never know he was on the autism spectrum, but I have the paper to prove that he is. And then all the way to the nonverbal patient who doesn't like to be touched and all of those things and everything in between. So if somebody just checks yes, we want to learn what that means and how can we help? And is this an appropriate place to start? And so that's why we're asking all of these questions. Do they need an interpreter? Can they walk? Do they need can they transfer to a chair? What types of things are they coming in with that we can be ready for? This is another part of it. So what helps them? They prefer soft touch, low light. They don't like guys. They're threatened by males. Okay, fine. So we'll find a female provider. Whatever the case is. I mean, I'm a big guy. I'm 6'5". And, so I can be intimidating to people. I'm well aware of that. And so, if I would be intimidating to somebody and we can find another provider that wouldn't be, again, I would love not to scare people. So this is stuff that we can learn ahead of time. They prefer morning appointments. They love talking about my son, my aforementioned son, his favorite thing in the world is music. And, so you talk to him about classic rock, he'll talk to you for an hour. Or maybe they like lions and jungle animals. I mean, if we can learn about that stuff ahead of time, that just makes for a more positive experience. If they've had physical restraint or protective stabilization as a child, that bodes well for them having it here or it being effective here. And so we'll ask about that. Yeah, they had that they went to a pediatric dentist until they aged out. And every single time they went, they were in a stabilizing device. Okay, fine, I have those. So now we know that that's something we should probably have at the ready for when they come here. That would be successful. We follow that up then with a telehealth or teledentistry call. This was something that I was asked to implement into the emergency clinic at Oregon Health and Science. And I did, and it worked. And I learned, I've never published a paper, but I'm told I have one that's about to be published about the effectiveness of teledentistry. And I'm actually very proud of it. It's what I learned about teledentistry is, we were able to shorten appointment times. We were able to cut down on angry patients whose expectations we didn't meet because they thought they were coming in and, what do you mean you're not going to take out my tooth today? And well, it's your first visit. We just met. So now we can say, I will try to take out your tooth, but I don't want to make a promise that I can. And, that type of thing. At least they know what they're getting into when they get here. And it's not to say that we please 100% of patients, because some patients can't be pleased, but at least we try. And at least we have that conversation. I can tell you that the number of disappointed patients has gone down dramatically because we can have these conversations in advance. Again, though, also we can fill in the blanks. Sometimes they just check a yes box. So now we can talk to them and say, can you articulate this yes? So we can be ready and learn more information. And so the teledentistry. So right now I have the students do it. Again, in Oregon, we incorporated it into the emergency clinic, and now they're doing it school-wide for all their new patients. All the students call their new patients that register and have this call and prepare their medical history and have their x-rays sent from the previous office and all of that. And it just makes their first visit that much more efficient. And so we're doing that too. Right now, the students are calling. So everybody that sends back a welcome packet, we review it, and then the students will call them to fill in any blanks. they also need to know, especially if they're coming from 2 hours, that the appointments here can be 2 hours, and then they have 2 hours back. So, you prepare accordingly, please. I mean, I don't know if you need an extra set of clothes or something like that, because it's, you're going to be out of the house for 6 hours. I mean, please prepare your patients accordingly. And so again, this isn't something that, you want to find out in the chair. It's too late that there was an accident or something and they're not prepared and they have a 2-hour drive home, or they're on supplemental oxygen and they didn't bring enough. And now they have to drive 2-hour drive home, and where's my tank and all of this. So these telehealth calls were crucial for success. With my previous employer, we're incorporating it here now. This is what the students have been doing this week. And what I'm hoping is that when they start seeing patients next week, they can use the information from these calls and apply it and be useful. So our clinic, these products are from a company called Specialized Care. And I'm trying to think, yeah, we have all of these in this clinic, and these are all little aids that can be used, from the rainbow wrap on the lower left to these clever bite blocks that have a hole for the saliva ejector, and a handle to manipulate the bite block, which I think is cool. The lower one with the big white stick, we call it a marshmallow stick. It's sort of a firm foam stick that can be used as a bite block and retractor. We're going to use those like crazy. I know it. We also have a wheelchair tilt, which is, I realize it's not practical for a lot of offices because they're not cheap, and this one was generously donated. But we have the ability, in somebody that does not have a powered chair, to put them into this wheelchair tilt, and they can go back pretty far. That person in that picture is about 45 degrees. They can go back. I've seen it done close to 90 degrees. It's almost supine. It's actually really impressive, the device. And it also has a bariatric bench component that slides in there that can accommodate up to 600 something pounds. Should a patient need that and they exceed the weight limit on a standard chair. So we also have wider operatories to accommodate people that can, slide in a wheelchair and then transfer themselves. But again, except for maybe the wheelchair tilt, these are all things that can be purchased for private practice use. They have a really extensive website with these, again, head stabilizers, rainbow wraps, the things on the left that hold your arms straight so you can't, come up and put your hands in your mouth when you're working and be grabby and that type of thing. So these products are all available to all practitioners. They have a really easy to navigate website. That's the website right there. Of course, it is important from the parent or guardian to obtain consent, because you are restraining the patient. But, with a proper consent form in these instruments and tools, it's a wonderful service to be able to offer. And it's certainly less invasive than an operator, an assistant, somebody else coming in holding arms, somebody else coming in holding legs, not to mention the patient. It's just that's a lot in one space. And so devices and aids like this can be extremely useful and helpful. When I interviewed here, I heard a lot of, thank God you're opening. We have so many patients that need to go to sleep. And believe me, again, I can empathize with that completely. That's just not a service we can offer. And, but I also think it's important to acknowledge the point of what's the goal of, say, sedation, moderate conscious sedation. Are we trying to reduce the patient's anxiety, or are we trying to induce compliance? And I was trained at basically at the dental anesthesia program in Ohio. This is where I'm basically certified in Oregon and Ohio. But I'm a safety guy. I'm not about let's just give them, and this whole thing where it says on the top, whatever's necessary to get the job done falls outside the limits set by the definition of conscious sedation. In other words, it's potentially inappropriate to just give enough medication that you can do what you need to do, because are you now crossing the line between a moderate sedation and a deep sedation? And should you be doing deep sedation without a general anesthesia permit? And it just raises a lot of questions. So I am of the school of, if you're equipped and handled to do moderate conscious sedation, then do that. But I've certainly maxed out enough people on a bunch of drugs to realize, okay, we need to stop this because we're really pushing the limits of safety. We should stop and consider something like a dental anesthesiologist or a hospital. Again, what's the goal? Is it anxiolysis or is it compliance? Because if it's compliance, then maybe you need to go another direction, say general anesthesia. So that's sort of an aside about my thoughts on sedation. But, if the patient does end up going to the hospital, we use these little, we called them R2, D2 units. And these are basically, self-contained dental operatories. They've got the suction, the handpiece, high speed, slow speed, saliva ejector. Some of them have curing lights attached, and you just wheel this in next to the operating room table and do what you need to do. Now, what I do caution is that if we do end up going to the operating room, because seeing them in any kind of outpatient setting is difficult or impossible, sometimes then we have to change what we hope the goal or the outcome would be. Because anytime anybody goes under general anesthesia, there's risk involved. And so taking them for 9 visits under general anesthesia isn't practical for a lot of reasons. It's not safe, it's expensive, it's just not something that I would do. So in order to maybe take them as few times as possible, ideally once, I certainly recommend with parents and caregivers that if we're going to the operating room, we should change our goal, and we should think about, instead of doing the root canal and crown, maybe we should think about taking out the tooth. That way you don't have to worry about the root canal failing. How am I going to get a final impression? When am I going to cement the crown? Those types of things. And that's just one tooth. What about the rest of the teeth? And, I've done cases that are long, 4.5 hours. And once you start to get over 3 hours, I think, the anesthesiologist, at least in my cases, start looking at their watch and wondering what you're doing. And doing that multiple times can be risky. And so, normally we just say, what do we need to do to get the mouth healthy? Can we fix it? Do we have to take it out? What do I need to do to get you healthy? And of course that changes, the tenor of the conversation with the parent or caregiver. But it is an option for those patients that need it. And it's a good option for a lot of different people. This is a whole other lecture in itself, but it is a possible outcome for patients that require it with special healthcare needs. Going to the operating room is, it's as a general dentist, it's certainly difficult to be profitable. Nobody goes, I tell people all the time, if I could get rich going to the hospital treating patients, I wouldn't be here teaching right now. It's hard when you're doing a bunch of 1 and 2 surface fillings in an operating room in a 3-hour case, one patient, to be profitable. And it's difficult to get privileges at a hospital. And I did a GPR, but it's, if you haven't, it's hard for the hospital to sort of put trust in your credentials application. It is a detailed and tedious process, but it is worth it, for an absolute certain segment of the population. The biggest thing that I try to teach the students and residents and that type of thing is, you don't know what's capable with a patient unless you try. I want to try to get them to a point where, they can look at every patient that comes in the door and at least try. I want to teach them not to be afraid. I want them to know what their limits are. I want them to be able to expand the boundaries of those limits, but I want them to try. And, because you never know what you can do. I mean, quick story. I got referred a patient once when I was, at one program 10, 15 years ago. And he looked like the guy in the picture. He had Down syndrome, but he was a nice kid. And he was referred for general anesthesia. And I sat him in the chair and I just said, hey, can we take some pictures of your teeth? And he said, yeah, sure. And we took x-rays and he needed 2 fillings. And I said, you want to do them right now? And he said, sure. And I did them, and he gave me a hug and he left. And it was kind of like, I don't really understand. I mean, I don't really understand why he was referred, much less referred for general anesthesia, except I can only think that the dentist that referred him didn't try. And that's what I'm trying to get these students to do is try. And maybe that means you fail, but at least maybe don't look at it as failure. You learn that there's probably a more appropriate venue for the patient. And we just need to do a little digging and homework what it is. But if I can teach them not to make a snap judgment about patients and at least make the effort and take the time to learn, I feel like that's kind of what this clinic is designed to do. Treatment of patients with special healthcare needs is certainly challenging. It's kind of what keeps me in it. Like I said, I had my own, I was an associate in practice and had my own practice for a while. And I think just for me, I think I got a little bored with the drill and fill, and treating patients where I had to think and maybe do things a little differently and work outside the box. I think that kind of got my motor going. And it does take patience, and it does take understanding, and it does take a lot of compromise and tolerance. But I feel like there's a lot of patients that can benefit from this, that do benefit from this. I get thank you cards and stuff. I mean, they're very grateful and appreciative that sometimes that you even tried. And so I think it's worth the effort. It does have a wonderful outcome a lot of times. And it's meeting the needs of a lot of patients that otherwise wouldn't get it. So I feel like I've been talking a lot. I see a couple of things in the chat. Let me see if I can.
Thank you so much.
Of course.
I can read them too as well if you want. So the first one was saying they struggled with terminology on how to turn specific conditions away without being accused of discrimination.
That's tough. And I think that, really, it's really, if you go back to the slide that I had about the ADA, again, it's not that you have to treat everybody, but I think that saying that you can't or won't and then closing the door. I mean, first of all, in a patient with a disability, you do run that risk of they're not seeing me because I'm in a wheelchair or whatever the case is. I think that, again, if it's in you to try, I would try. If for no other reason than patients and caregivers know that they can see when it's not working. And a lot of people, again, appreciate the effort. So there may be benefit to saying, hey, look, I'm going to, and that's kind of what we do here. We're going to try. I'm not making any promises or guaranteeing an outcome. And you might end up being referred out of here. But I'm really just trying to find the best, safest place for you to be treated. And that may or may not be here, and that may or may not be by me. If you try, you can just say, my office isn't equipped to handle this. I'm not equipped to handle this. I tried, it didn't work. here's what I think we should try instead. And then maybe you send them to another office or refer them out. But I think that, I think especially if you're, quote unquote, just turning people away, I think you are opening yourself up for some potential problems. If you at least try and fail, you can say you tried. And then if it doesn't work, then it doesn't work. But now you're trying to find an appropriate place. People get angry, I think, when they feel like you're just turning your back on them. And so I think that at least if you put in the effort in, make the direct, honest contact, then I feel like that will decrease the chances of being accused of discrimination.
And the follow-up to that was saying disabled people opens it up to every person with back pain or cannabis card. Cognitive disabilities opens up to those with mild dementia that can be treated elsewhere, etc. So I think what I gather is concerned with opening it too broadly. And then you can clarify that. Excuse me.
Well, I think that's that's kind of why, when I use those labels, if you will, I think I was just using them for the points of conversation, but I don't know anything to say there other than that's why we have to be careful with labels and how words are phrased. At the end of the day, you have control over who you see, who you treat, who you let in your practice. But I do think that, labeling and that type of thing can certainly present itself with some of those challenges. The next question I see is certification for rainbow wraps. I'm not aware of certification. I am aware of, I would strongly recommend consent. But there really isn't anything to a rainbow wrap other than, it's, back in the day, they called them papoose boards. We don't call them that anymore, but rainbow wraps, it's really just that. It's sort of a Velcro blanket that you put over their arms and or legs. I'm not aware of a certification. I've been using them for a long time. I do get everybody consented for them though. So that's all I can say there. Most patients have serious mobility issues. How can we get the training needed to do case selection and treat the patients that can be treated here? Well, I think my question is, my point is, that's sort of taking a look at what you can provide as a person and an office, what you're comfortable with. And, being honest, I found that case selection is vastly improved with the information gathering ahead of time, whether that's paper or the teledentistry calls. Because somebody will say they're in a wheelchair and I saw a lady this morning that's in a wheelchair and I said, are you able to transfer to a dental chair? And she started standing up and was like, sure, you want me in there right now? Oh, no, I don't, but I just was curious. And, so then there's people in a wheelchair whose arms are contracted or they're quadriplegic and, it's, they cannot. And so I think that's the question about case selection. Training, again, I don't know that there is specific training. I can tell you that Penn Dental Medicine, if you go to Penn Dental Medicine and go to their continuing education section and navigate to the it's really big. You can't miss it. But there's a whole thing about disabilities, patients with disabilities. They have a huge list of archived webinars on treating patients with disabilities. Besides that, I don't know of any specific training available for patients with mobility and issues. But I think that's a great place to start. As far as patients that can be treated here or in your place, I think that's about information gathering and having those conversations ahead of time.
And then it looks like the next one is about reimbursement.
I need some more information. Because for example, like reimbursement for teledentistry, there isn't any. It's not a, I mean, we use it as a tracking code. We file an ADA code. It's D9995. We're just doing it as a tracking code right now. Some of the rules surrounding teledentistry are a little weird as far as trying to submit for reimbursement. I feel like it is coming along. I feel like it will reach a point where it is a reimbursable charge, but right now it's not. And the rest of it honestly is just like, I mean, if I do a filling, I do a filling and I charge them, you know, just like anybody else. There is another code for providing accommodations, but again, it's like D9997, I think. That's when you have to provide accommodation, but you have to document it. And I don't know that that's necessarily a billable code either. So for the moment, we're just providing, you know, say a restoration code like we would for any other restoration, or cleaning just like any other cleaning. It is a little extra work and it is a lot more time, but hopefully when these other codes come online, like I say, the D9997, for example, that will allow for additional reimbursement. But right now, I don't think that it is. We always ask why they can't see a GP. Yeah, and I think, like I said, I think the reason is because, you know, I think there are a lot of GPs that, you know, can't or won't, or they don't feel like they can, or they don't, you know, want to take the time. I mean, it's not really glamorous. I mean, it's not doing 6 porcelain veneers, and it's certainly not as profitable. So I think that, you know, and there's people that just aren't comfortable, and that's, I can't fault them for that. I mean, I'm not comfortable doing root canals. I mean, I haven't done a root canal in 20 years. And so, you know, I think that people, once they get into practice, sort of reach their own comfort with what they're happy doing and comfortable doing. And I think that GPs that are comfortable, happy, and willing to see patients with special healthcare needs, especially the ones on the little more severe end, they're a challenge. And so it is difficult to find a provider that can do that. I see it's 2 o'clock. So I'm going to go ahead and turn it back over to Renee. My UMISH email is on there. I'm happy to field questions at any time offline. Just keep in mind that is not a secure email address. So please, you know, don't send any patient specific information. But if you have any general questions or whatever, I'm happy to communicate with you. So please send them my way.
Thank you so much for being here, Dr. Chervo. We truly appreciate your time and willingness to participate with us. So thank you. And
My pleasure.
If you guys do have any questions, please feel free to email myself or him, and I can get you over to Dr. Chervo there. I will share my screen. I did drop your link in the chat, but I will post it up here too for the QR code. So, and if there's any last minute questions, feel free to unmute yourself or type them in the chat. We can, while you guys are signing on to your evaluation, you can ask another question. Yeah, lots of thank yous. Yes. And thank you so much. And your certificates should auto-populate at the end of the evaluation. If you have any problems, my email is right there on the screen, or you should have it from the link that I sent you guys earlier.